Okay, I think we'll get started now. Welcome, everybody. Hope you're having a nice day. I want to welcome you to the American Indian and Alaska Native Mental Health Webinar Series. Today we have Dr. Dale Walker and Dr. Ken Winters here to present on intervention in first episode psychosis, approaches and difficulties for American Indians and Alaska Native communities. This training series is brought to you by the National American Indian and Alaska Native Mental Health Technology Transfer Center. We are part of the MHTTC network, which also includes 10 regional centers that you can see here on this map, a network coordinating office, and the National Hispanic and Latino MHTTC. This project is supported by the Substance Abuse and Mental Health Services Administration. The content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native MHTTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, the handouts of the slides, and a CEU request form. Our center is a NASDAQ-certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. Immediately following today's webinar, you will be redirected to our GIPR evaluation. The survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of the webinar, so please use the chat pod to share your questions and comments, and we will address questions at appropriate points after the presentation. Our first speaker today is going to be Dr. Roger Dale Walker. Dr. Walker is a Professor Emeritus of Psychiatry and Professor of Public Health and Preventative Medicine at the Oregon Health and Science University. And he's also the director of the One Sky Center, which is a national research center for American Indians and Alaska Natives dedicated to improving prevention and treatment of substance abuse and mental illness for Native peoples. We also have Dr. Ken Winters, and he is joining us today. He's a senior scientist at the Oregon Research Institute and adjunct faculty with the Department of Psychiatry at the University of Minnesota Medical School. He has published numerous articles based on his research in the prevention and treatment of adolescent drug abuse, and serves on the editorial boards for a number of journals, including Psychology of Addictive Behaviors and the Journal of Child and Adolescent Substance Abuse. Dr. Walker and Dr. Winters, thank you so much for being with us today and sharing your expertise on this subject. We will put up your slides, and I will hand things over to you at this point. I want to thank you guys for attending. This is Megan Dotson, Program Manager for the Mental Health Technology Transfer Center here in Iowa City. Thank you.
And hello everyone, this is Dale Walker. I'm going to be presenting it first, and then Ken will come in and present, and then I'll do some final words at the end of the presentation. It's a pleasure to be here with all of you. I see there's a huge number really, and we're growing as we go through the presentation on first episode psychosis and how it impacts American Indian communities. As I go through this, I might use the phrase Indian for American Indian, Alaska Native, or American Indian. These are kind of interchangeable depending on where we are, but I'm speaking for a broad group of large tribes, over 700 tribes, and we need to be aware of that and the differences among them, which will be a part of our discussion today. So the first thing is to talk about the learning objectives, and today we want to gain an understanding about the onset of first episode psychosis and understand the benefits of earlier detection and treatment. Next, we want to look at the latest treatment approaches and how those have unfolded across the United States over the last 6 or 7 years. And finally, we want to discuss the treatment approaches as they apply to Native communities. To start off, I thought it would be useful to hear the words of some young people who are experiencing those initial phases of a psychotic episode and what it has meant to them as they observe the process and how it affects their thinking and the function of their brain. These are quotes that were taken from Dr. Kate Hardy in her presentation earlier, and I thought that she would be happy for me to share them with you. You can't even sleep at night. Just there thinking someone is going to come. I thought I was in a movie. I'm dreaming, but it's not a dream. I don't feel close to anyone. I don't properly fit anywhere. I'm alone in a crowd. That's how I describe it. I was just getting worse and worse. Hearing noise. I even broke my radio in my bedroom. I just had enough. Just couldn't take it. I have to speak to someone. To start out, we want to talk about the causes of psychosis, and it's difficult to know what will cause a first episode psychosis. It's a complex process that has multiple focus and difficulties. Current research suggests that it's a combination of biological factors. They create a situation where a person is vulnerable to or at greater risk of developing psychotic symptoms. There's a number of brain chemicals that are discussed, but it primarily addresses dopamine and serotonin, which may play a role in psychosis as it develops. A stressful life event may trigger psychotic symptoms in a person who is vulnerable. I want to make that point clear because in American Indian country, that's a big issue about stressful life events. In the first episode of psychosis, the cause may be particularly unclear and complicated by developmental issues that the individual has in their life plan. It's important for the individual to have a thorough medical and psychological assessment to rule out any physical illness that may be the cause of the psychosis. Ken, you might want to step in now.
Excellent. Thank you, Dale, and welcome everyone. So for this part of the webinar, I'm going to provide some description both at a general level and then get fairly specific about what we mean with first episode psychosis. Simply, we're talking about the first time someone experiences psychotic symptoms or has a psychotic episode. These symptoms will get described real soon. As might be implied with the phrase first episode, it probably occurs fairly early in life, and in most instances, as best as we know, the young adult years, the 18 to 24-year-old period, is when most people would first start to experience this if they're going to develop a psychotic disorder. It can occur sooner in some, even as early as the early teenage years. I think we're not sure yet what might distinguish those that have the very early version versus the more common onset period. Males tend to have a little bit earlier onset than females by an average of 1 to 2 years. But we are really talking about dealing with individuals who may develop something quite severe, and it's early in their life. And so that's very relevant to treatment issues because early treatment is very important, but it means you're probably dealing with a young person. So having experience in adolescent and young adult treatment is quite valuable. So I'm having trouble moving. I'll go here. There we go. So a little bit about the experience of a person who might be starting to show early signs. The literature describes people with a common theme of they just don't understand what is happening. There's changes going on in their life, quite unusual changes, and they don't understand the source. You can imagine when that happens, it's very distressing to the person and those around them, because they're probably very rare type or unusual type experiences that the person is feeling and talking about. The key, though, is to distinguish what are psychotic symptoms versus what would be something quite different and not anything close to being a serious illness. There's two main themes. One is that the disturbances that are occurring in the person are across the board, not just in their mood or their emotions, but it also can impact the thinking and their behavior. And they're so serious that they significantly impact in a negative way the daily functioning of the person. So that means it's not transitory. It's not at the mild or low severe end, but it would have to satisfy these two general characteristics: severe and impacting somebody's functioning. I'm going to use a weather metaphor to further make my point here. So I'm showing you a tornado for two reasons. One is we know tornadoes are relatively rare, like psychosis, but we also know when they strike, they're very severe, not only right in the immediate region, but the collateral damage can be quite significant. And that would be the metaphor for the finding that and the experience that an individual who suffers from first episode psychosis also finds that significant others are impacted. So psychotic disorder, like a tornado, is rare. Maybe only about 1% to 2% of people will experience psychosis in their life, but it's very devastating to the individual and to significant others. I want to dispel a myth. Some people think schizophrenia or psychosis means a person has a split personality and is two different people. That isn't the case. A person can have a period of symptoms where they do seem quite different than when they're in remission. And so that is the case, because even with a severe psychosis, people can get better and can return to normalcy or near normalcy. But it doesn't mean that one is two different people. For clinicians to correctly diagnose psychosis, there's many challenges. I'm going to highlight three of them. The first is to remind you that it needs to be distinguished from what we might see in people that are considered more temporary problems with mood, thinking, or behavior. And I reflected on this and realized that in some ways, a certain period of one's life, developmentally, often is characterized by occasional but also somewhat striking changes in mood and behavior, and that would be the period of adolescence. In some ways, typical and very normal adolescent behaviors can mimic a behavioral or mental disorder, but only mimic and not reflect it. As you may know, have experienced yourself, or perhaps are raising a teenager or dealing with them in the clinical level, adolescence can be characterized by many features: resistance to authority, irritability, emotionality, etc. And some of these things might appear to an individual as, a great change in behavior, and is that the sign of mental illness? But not the case. Normal adolescence is actually, and healthy adolescence is characterized by some turmoil. A second challenge is this general category of not confusing it with other experiences someone might have that could mimic symptoms of psychosis. This could be changes in a person due to a physical condition, due to the acute effects of drug use, or somebody may just develop certain beliefs on a political, cultural, or religious level that might be at variance with the norm of a given family or community, but would not reflect that they have a psychosis. It can just reflect people can develop different beliefs. And sometimes those are at the extreme level of what might be considered the norm in a community, but would not be considered mental illness or a sign of it. And the third point I want to raise is the importance when there is an interest or a need to assess a person for possible signs of psychosis, that the clinical assessment process use suitable questionnaires and interviews. There are excellent, reliable, and valid instruments to make sure that they're appropriate for your community. For American Indian and Alaska Native individuals is paramount. And many of the good ones that I know of in the literature are suitable across diverse ethnic groups, but the good clinicians will adjust them accordingly. And one adjustment is to make sure you also understand the social context of the individual, both family-wise, local community-wise, so that you understand experiences a person is discussing is not incorrectly assumed to be a sign of mental illness, but may just importantly and significantly reflect a social context. First episode psychosis can be described as having three phases: the prodrome, acute, and recovery. I'll briefly describe these phases. Prodrome would be the phase that precedes having the severe version of psychosis. It would be sometimes called the subclinical version or period, where someone is showing early signs of difficulty. The signs may be quite vague and in some ways not very noticeable, particularly of the significant others of the individual. But there are some classic prodromal features. They will differ among everyone. And so while these are common that I've listed here, there's variability, and to the extent an individual in this phase will display them. But you can see that they reflect emotion, behavior, and thinking. For example, on the emotion side, reduced concentration. There can be depressed mood. There can be a decrease in one's motivation. There's also can be greater anxiety, and perhaps reflective of the fact person's realizing some things aren't just right with him or her, and that can surely lead to a natural reaction of anxiety. Behaviorally, individuals might notice that they're showing a deterioration in functioning. So for a young adult, they might be no longer engaged in school or college, or if they were employed, they might be pulling back from interest in employment. There might be withdrawal from family and friends, as well as lack of interest in engaging in social activities that he or she typically were involved in. And then there can be some signs related to showing some suspiciousness or other kinds of beliefs that might be a bit unusual or odd. The next phase is called the acute phase, and this is when the symptoms of psychosis begin to emerge. It is also known as the critical period, and in this phase there's really clear symptoms of the symptoms, clear signs of the symptoms. There are 5 major categories. You can see they span the 3 features of emotion, behavior, and thinking. The first 2 have really directly related to issues of beliefs and thinking. Confused thinking, where thoughts can be muddled or confused. The person may not make sense when speaking, may have difficulty concentrating. The person may complain that their mind seems to be racing and they're having difficulty processing information, understanding what you're saying, taking that information and applying it appropriately. False beliefs can start to emerge when they're severe and detailed. They're called delusions, and they can range. They can For example, belief in a different kind of reality, that and they're very steadfast in those beliefs, and the person can be not talked out of it. Almost no amount of logical argument can dissuade the person when they're in the throes of a delusional belief system. Examples that have been described in the literature quite a bit, and you may have seen in clients, are things like believing that someone is watching them, such as the police, or they might think they're receiving special messages from things like the television or the radio or their cell phone. Hallucinations can occur. This is when a person says they're seeing, hearing, feeling, smelling, or tasting something that is not actually there. Hearing voices would be very common, and often these voices are linked to their false beliefs. Changed feelings and changed behavior are the last two. And these really reflect that the person says they're feeling something quite different, and there doesn't seem to be a logical reason for it. They may feel quite strange or cut off from the world, or they've got a mood swing that just doesn't make sense with what's been going on in their life or around them at the time. And changed behavior really can be an extension of what might have been seen in the prodromal phase. They're starting withdrawal, lack of motivation, feeling perhaps that the hallucinations and delusions are so severe that they're having trouble just functioning with daily activities. One thing I wanted to bring up related to onset of psychosis is this emerging data suggesting the unfortunate role of cannabis use and onset of psychosis. So what you see here is results from a meta-analysis, which it was a statistical way of summarizing several studies. And above each bar, there's a number, and there's 3 bars: alcohol, cannabis, any drug. And the number above the bar reflects how many years earlier the onset of psychosis occurred in the group that used the drug compared to a group that eventually showed psychosis but didn't use the drug. And so the main take home from this slide is the middle bar, cannabis, and the number above it is 2.7. So that meant that among groups of individuals who all had psychosis, among those that used cannabis early in life, they had the onset of their psychosis almost 3 years earlier than the group that didn't use cannabis. So everyone develops psychosis, but this just shows how early use of substances can alter the onset. So suffering from the disorder almost 3 years earlier is a negative. It also likely means that the course of their disorder will be more severe. So alcohol, way to the left, which is 0.28, which basically meant early alcohol use didn't alter psychosis onset. In the far right, anti-drug, that's where they lumped all substance use, because many people use something else besides cannabis. So it's not good news even if you're using other illicit drugs. You're still altering things in a negative way. Given how America is getting more pro-marijuana in terms of legalization, I thought it'd be important to put a little spotlight on the issue of cannabis and our discussion of psychosis. And the final phase, the recovery phase. And this is really, a good news story, because with effective treatment, most people will recover from their first episode of psychosis and may never have another episode. But it's important to remember that psychosis is a treatable condition. And particularly if help and treatment is sought early, an individual may never suffer another episode, or if they do suffer again, it will be a much milder version of the signs and symptoms. During recovery, though, some symptoms may still linger, but if treatment is persistent and continues, most people will be able to show successful recovery and turn to normal everyday lives. As Dale is going to talk about real soon, keeping in mind that treatment works and early treatment really helps treatment work is a key take-home principle from today's workshop. Okay, back to Dale.
Well, Ken, thank you very much for the information and reviewing the signs and symptoms and the phases that one goes through. As we've worked with, psychotic episode, especially since the 1950s until now, when we attempt to work with this, it's always been difficult to understand the process. Some things that we know, however, is that the longer you delay treatment, the worse the treatment prognosis. There's a greater chance of aggression and violence. There's social and role dysfunction. By that, many times the young people, they become withdrawn, they don't communicate, they become isolated, and their roles, either in work or in school, are quite difficult to maintain. It takes a longer time to recovery, and it's less likely to recover from that first episode. So the longer you delay, the worse the treatment prognosis. Chronic symptoms are more severe in social role function, and greater risk of brain tissue loss have been observed. Now I'm trying to move my slide along and I can't seem to do it.
Go to the arrow, yeah.
Well, I didn't need the arrow the first time, but I do now.
Yeah.
One of the things about the severity of these problems, and the longer the delay in treatment, the worse the outcome, that prompted the federal government, along with the National Institute of Health, National Institute of Mental Health, and SAMHSA, to earmark 10% of their funding in mental health to look at first episode psychosis. Now, that's a phenomenal admission to the problem. The thing about first episode psychosis is it's incredibly expensive to deal with after you have full-blown problems with psychosis. And so the earlier you intervene, the better chance of recovery. It's more cost effective, and it also maintains good care for that individual. This chart shows you that in about 2008, the organizations were trying to prepare for how to manage nationwide these problems and issues. And as you can tell, in 2014, money has been set aside in state block grants to look at developing recovery programs across the country. $100 million were spent in 16 and 17. We now have programs in nearly every state. The reason I wanted to show this slide to you is that if you're out there in Indian country or in urban Indian programs, you can contract your state mental health programs to ask for advice, consultation, treatment referral, and maybe bring people in to help you in developing your programs. There are resources and monies available to do that. It's tempting, when states receive the money, they're not first to think about reservations and urban Indian peoples. And so it's important that you reach out to these organizations, ask for help, and ask for advice on how to set up your own programs. Now, I realize the model that we're going to talk about is very difficult to administer in urban settings, but I wanted to share with you a little bit about how one might go through the process. The first point I want to make is that these first episode psychosis, they occur just at the age when other serious mental health disorders are happening. And so they're complicated because of substance use, anxiety disorders, and depression. These things occur at the same time, and it's hard to kind of work through the process. So as we look at this, we have to tease out the problem and look at the circumstances as they occur. Now, in American Indian communities, that is complicated because the risk for other mental health problems and historical trauma make things even more complicated. This is a slide on native mental illness, a multi-factorial event that I put together to try to, when I talk with native communities and tribal councils, I try to point out the various episodes that affect the individual. So that individual person has their own biologic risks for a first break psychosis or mental illness, but they also have cultural distress, substance use and abuse, family disruption and domestic violence, negative boarding schools, historical trauma. If you just go around the circle and you see all of these problems are occurring within that individual. And remember that those events increase the risk for psychotic episodes. When looking at adolescent risk factors, there are 4 big ones that we think about in looking with the adolescent American Indian Alaska Native people. Aggressive and impulsive behaviors, substance abuse of great variety of all types, trauma, and depression. So these are all risk factors now for first break psychosis, and they complicate the process. The aims at early intervention that Ken was beginning to talk about are fourfold in what's called an evidence-based approach, as the National Institute of Mental Health has been describing. You want to prevent psychosis in the ultra-high-risk individuals. That means you need to identify them and intervene early, right at the cusp of the problem. You want to reduce the duration of untreated psychosis and promote early detection, comprehensive initial mental health assessment. I realize saying these things, those of you out in Indian country are saying, oh yeah, we can do that, that's no problem, we don't have the system or structure in place. And so it's tremendously challenging, and I'll go through some ideas about how maybe we can address that. You want to optimize the initial experience in acute care and treatment so that it's youth friendly. That can be done better, in my opinion, in Native communities than average. Finally, you want to maximize recovery and prevent relapse during that critical period. You want to provide outreach and integrated biopsychosocial interventions. You want to focus on the function and vocational activities of the individual and keep them employed or in school, addressing comorbidity like addictions, anxiety disorders, and depression, and then support the careers and network of community support agencies. The carers, the people who are providing care in the community. You need to support them. Now, this slide talks about the early stages of intervention that Ken pointed out. The first thing I want to point is the bottom line on Prodrome, first episode, 88% recover in that first episode. In the second episode, only 57, the third episode, 32, the fourth, even lower. And you have that normal stage of development. So the idea of the duration of untreated psychosis, the acute care, and recovery relapse. There are the 4 points that you want to develop and target treatment intervention in order to help the individual get back up to the normal development stage instead of going down the path of psychotic behavior. Now, all of this occurs right when developmentally sensitive issues are happening. If you look at the middle of the slide, you see kind of the stages of development from conception to the late teens. And you know that as those stages from preschool to primary to puberty to late teens, those are often difficult times in searching for control, identity, and who a person is and how they're functioning in life. And so you can see how working with families to help them cope, first of all, with the changes of maturation, and then address the clinical risk symptoms of psychotic behavior would be quite difficult. Now, in Native American communities, have done well in focusing on risk and protective factors as one way to kind of develop your treatment strategies. We know that there are risk factors for acute psychosis, and we know that other mental illness like depression and anxiety are risk factors. Young age and male is a risk factor, but frankly, female has the same issues, just it's a little bit later in the stage, not many, maybe 2 or 3 years later in expression. Substance abuse, loss, I want to put that in because communities in native world have tremendous loss issues to deal with. Loss in suicide, loss of job, loss of education opportunity, loss of having food. All of those issues are important. Previous suicide attempts, personality traits, incarceration, failure in academic. By the way, that's one of the biggest predictors for wanting to pay attention. If you have a person who's functioning well, doing well, and all at once they're starting to have failure in academic efforts, that's an important time to do assessments. Now, moving over to the other column on the right, there are also protective factors that you as treatment people in Indian country want to understand that community's protective factors. They might be different. As a matter of fact, if I have anything to share with you today, protective factors and culture go hand in hand. It can be true in inner city Philadelphia. It can be true in any rural place across the country, and it's true in Indian country, that you want to understand the cultural and religious beliefs as well as coping and problem-solving strategies that exist within the community. You as a treatment provider must learn how the community's protective factors work, and they vary just a little bit from place to place. Well, how might you use those? And one model that I use is I try to look at the domains that influence behavioral health. Now, this is an ecological model, and if you look at the at the left, there's the individual with their issues, their biologic aspects, and then there's the peers and the family. Next level is community and tribe, and then society and cultural. Now that's, you all, if you are working on reservations, you know that there's stress inside the reservation and outside the reservation. Those issues are predictors of first break psychosis, and you want to look at those from both a risk and protective way. The risk factors, you make a list of what are the individual risks, what are the peer group risks, the family, the community and tribe. All of those issues are true. So you collect the information about what the risks are. Is there stress within the society? If I go to any tribal community, it's always an important issue to find out how are they functioning with the people that surround their community. Now, protection is equally done. You make a list of what are the protective factors about the individual, the peer and family group, and as community and society. So as you make a list of that information, it will help guide you with the next step in treatment process. And that is coordinated care management. This is what the scientific world says is the evidence-based practice. And frankly, in Indian country, we can see this. We know that case management from a social service perspective, developing problem-solving skills and helping to manage meds and coordinate services is the important thing. How do you bring all of those pieces together to help a family and to help an individual? Family support and education. I just want to share for a moment, this is so critical in Indian country. We really need to understand that our families need help. And the family, just the structure and the survival, finding enough food, finding a home, finding employment. All of those things are happening as the child is developing, and their issues are a part of the whole family structure and stress. And we need to understand that better as we develop a treatment outline. Psychotherapy really helps the person manage the condition and promote wellness. Anybody can do psychotherapy if they have the training to do that, from counselors to nurses to psychologists, physicians, psychiatrists, religious leaders, and elders. All of these people can provide help and support. Medication management, we'll talk about in a little bit, but finding the best medication at the lowest possible dose is the goal. We want to support education and employment, support the peers, and keep people involved in their community. I list for you two things at the bottom there. NAMI stands for the National Alliance for Mentally Ill. They have a helpline, and I give that phone number. And you might call from your community and say, is there anybody near you that can provide help and assistance? The National Alliance for the Mentally Ill is a collection of families and peer groups who are struggling with mental illness, and they are the advocates for people, and that peer support is critical to maintain. It's throughout the country, and invite them to come and talk with you. The other thing to do is to contact your state mental health program to find out if some of those resources can be brought in to help you in providing support and care. Now, the overall aim for first episode care is to work with the delusions, work with the hallucinations, and work with the negative symptoms that people have. Now, the overall goal is to reduce the anxiety, the distress, and the disability. The way to do that is to provide behavioral control, find ways to help the person deal with the problems by relaxation, sweat lodge, going for a walk. What do they do when the voices start to overpower them? Once they understand in their head that these voices are intrusive, they're real, what can they do to deal with that situation? That's cognitive behavioral therapy, finding a trigger to help them get away from the problem. Socialization, finding friends and keeping friends when you have this problem is a critical point. Day centers and recreation. I always mention recreation when I talk about Native communities, because the recreation therapist or counselor is such a critical person in Indian country, and they know a lot about what's going on with the kids. I would involve them if I was going to develop a program for first break psychotic behavior. Medical care and control of medication is always an issue, and we really need to think about that and keep the patient involved. You should involve and educate them about why you're taking medications. Try to reduce that control and fear about medications and what it might mean. And then the symptomatic behavior. We all know that wheels fall off the cars. People get drunk, people get drugged, they have problems, they react inappropriately, they might punch policemen. We need to be very aware of that and monitor the behavior and help to kind of intervene before these things can happen. And finally, cognitive control. What does the person do to relax or to get away from the voices or the distortions in their mind? Does TV help or hurt? Does music help? Crosswords, things that help occupy their thinking to reduce the voices and the problems that they're feeling. Above all, you need to develop a dialogue with the patient. I couldn't emphasize that more, that somehow someone needs to communicate and help disarm the fear and the isolation in such a way that the patient can understand that they can get better. There is hope. These things will get better. They will go away. And they need to be encouraged to play a role in the process. So the positive symptoms are always important. And when you optimize the medication regimes, usually that's a low dose of care. You don't want to start with normal doses. Usually about half the dose for an adult is what is said to be the start. I would actually recommend about a third of the dose for native communities, because medicines, indeed, as opposed to drug abuse, medicines are very rare in Indian country, and we want to use them carefully. So you manage the positive symptoms, especially ideas of reference and voices and thought broadcasting. Now, you all know what ideas of references is. That's an event or an event or a special meaning to a circumstance that happens. They might feel that they've been anointed to hurt someone, or their birthday might be related to something that they must do in reaction. So we want to think about ideas of reference. You manage depression and anxiety, agoraphobia, when they're uncomfortable with circumstances and special situations. So the negative symptoms are an interesting problem to deal with, because the negative symptoms are withdrawal and not wanting to kind of be around people because the voices are made worse. Sometimes you need to consider the protective function of isolation. They're trying to avoid and prevent overstimulation, and so you want to give them quiet times or opportunities to step back, but you don't want them to be isolated. So protection from relapse is a positive symptoms. And then you want to assess how much pressure the patient and the family perceive. Now, families have to deal with the stigma. They have to deal with the embarrassment and the fact that bad things are going on. And they also need to worry that, is it my fault that this happened? And so working with the family to reduce pressure, review immediate expectations, and use a realistic long-term planning process. You might have to take a year off and then reconsider how to manage college. So reducing the level of activity if it's causing distress. The overall aim is to reduce distress and disability and promote empowerment and recovery. I believe that empowerment and recovery are the two most important words in Indian country, and we really need to make sure that the patient, while they're young, they might not feel empowered as you're trying to give them medicine, change their behavior, put them in an inpatient setting, and you need to really bring them into the system so they're a part of the team. When I work with American Indian communities, I try to take what's known on the left in the Western world about what a best practice is. It's research, science, and scholarship combined with community standard of practice. Well, in Indian country, we need to work, and frankly in all country, not just Indian, but once again, inner city Philadelphia, New York, we need to understand the cultural values of the people who live there. What are their philosophies about problems and difficulties that occur in their community? We need to understand and appreciate and take that into the process. We need to understand their theory about why are things happening, and then incorporate that as best we can into the treatment process. Is there local innovation? Is there trial and error that seems to work? How about the traditional medicines? Do we want to partner with the people who are doing this? Do we want to partner with medicine men? Do we want to partner with elders? I say yes. We need to work with these groups in order to provide the best practice available for a community. So if you look at community social network and the ecological model that I've presented, on the left you see medical care, mental health, and addictions treatment and social services. Those are the typical things that we see when the individual, the family, the community, and the society are involved. But we need to include schools, churches, recreation programs, housing, justice law, tribal council, administration, human resources, and public safety. Somehow in Indian country, we need to reach beyond the healthcare model to provide a much better embraceable program to look at jobs, housing, employment, school setting, and the whole bit. So evidence-based interventions are just that: psychoeducation, coordinated treatment by a multidisciplinary team, cognitive behavioral therapy, medication management, employment and education supported, and community outreach. Those things can be done using an American Indian model and fit nicely within evidence-based interventions. Why do we want to do this? Well, early intervention can result in preservation of brain function, preservation of psychosocial skills, reduced morbidity, decreased need for hospitalization, preservation of family support, rapid recovery, better prognosis, and less need for medication. Quickly, I'll mention medication. There's a model that you use here. Guidelines differ across the country on what kinds of medicines to use, but there's agreement that olanzapine and clozapine should not be used in first line due to their side effects. In the RAISE-ETP, and RAISE-ETP stands for Recovery After Initial Schizophrenic Episode, and ETP is Early Treatment Program. If you Google those two collections of letters, RAISE-ETP, they'll give you information about how to manage an evidence-based program. Well, RAISE recommends that chlorpromazine and haloperidol, which are first-level antipsychotic drugs, should be used in second line due to their side effects. Their first-line agents for remaining medications are aripiprazole, quetiapine, risperidone, and ziprasidone. These are the drugs that are being used, and again, I would use 1/3 to 1/2 the adult dose in getting started. Follow it over a 4-month period of time. See where you are with the individual, continually addressing both biologic assessment as well as any side effects to these medications. Make the patient a partner in your medical care. So finally, we really know that families play a critical role in recovery. Families often bear their own burdens. And by the way, families have something called expressed emotions, and those expressed emotions will predict second and third psychotic episodes, and so you want to understand that process. Engagement often requires skill building for the family and for the individual, and engagement activities must respect the choice to terminate treatment. So that would conclude my discussion. We have a little bit of time, I think, for questions. I do have a contact there if you want to talk to me about the issues, or email me. That's my phone number and my email. You certainly are welcome to join the oneskycenter.org as well. Thank you very much.
Okay, everybody. I think now is a good time to open up the floor for questions. Go ahead and type in the chat box, and I'll read it out loud.
Megan?
Yeah.
Why don't I can answer Dorothy's question that
Sure.
she posed a little bit back. I'm sure she's referring to that one slide that was comparing alcohol, cannabis, and all drugs with the impact of those drugs on onset of psychosis. And if I understand her question correctly, yes, the samples that were used in that big meta-analysis, everyone had psychosis. So it's not looking at the relative risk of getting a psychosis if you use cannabis. It was just comparing among people who have psychosis how the use of drugs might have created some differences of when a person got their first symptoms. Yeah, there's the slide. I think Dorothy said she understands now. Yeah. So everyone has psychosis. It doesn't tell us the relative risk of developing among a population sample. That's a different story. Different, very complicated question that we could address at another time.
Okay. We have another question from Carol, Dr. Winters. You mentioned something about cannabis use being on first psychotic episode almost 3 years earlier. Is there any evidence that cannabis use brings on such symptoms in those who wouldn't already be predisposed for psychosis?
Okay, excellent, Carol. So my understanding of what we know about cannabis and how it can alter risk of developing psychosis is that it probably is not a single causal factor. It likely is contributing to a greater probability of having psychosis if you already have a genetic predisposition. In fact, there's even been some work that a specific gene that's related to neurotransmitter functioning might be the culprit of that interaction between cannabis and onset of schizophrenia and other psychotic disorders. So my understanding when I've read the experts who weighed in on this, that they don't claim that without some predispositional factor, taking marijuana would be a single cause of a psychotic disorder, but alters risk for people that might have a predisposition. So it's important, risk factor. One other side note, much of the research that has weighed in on this topic is based on marijuana that was much weaker than what is currently available to communities. So the strains of THC are so much higher than earlier generations that much of what we say about the role of cannabis and health is looking in the rearview mirror, because that literature is based on the plant that had potency levels of around 3 to 5% THC, and nowadays the potency is 3, 5, 10 times higher than that. So that could make things much riskier.
Okay, we'll see if any more questions come in here in the last 2 minutes of our presentation. Somebody's typing. Well, if there's no more questions for today, I'd like to thank the two of you for presenting. This was excellent. And just to remind everyone that the slides from the presentation will come in a PDF format to the email address that you've provided after this webinar. And then if you do have the time to take, please fill out our evaluation at the end. It should pop up in your browser. Anything else? Question-wise, you can email to me at megan-dotson@uiowa.edu, and I can always get in contact with either one of these gentlemen if you think of something later on. All right. Thanks, everybody. Hope you had a good day, and we'll talk to you again soon. Thanks.
Thank you a lot, everybody. Goodbye.
Thank you, everyone.
Thank you, Ken.
Dale, pleasure.
Bye-bye.
Bye.